Hello, I'm Sue Swindells from the University of Nebraska Medical Center in the US, and I would like to thank the organizers for giving me the opportunity today to talk to you about improved adherence with non-oral medications. What are the data? Here are my disclosures. So, non-oral medications can take many forms as illustrated on this slide, but for HIV specifically, we have two in development by long-acting injection, and there's also some interest in implant formulations, mostly for the PrEP indication. So these others are less advanced for the HIV space. And I don't need to tell this audience that medication adherence is a major issue in HIV. So on the left is a study I did some 20 years ago now with protease inhibitor-based therapy. And the histogram shows rates of virologic failure on the y-axis and adherence levels as measured by electronic bottle tops, MEMS caps, on the x-axis. And as you can see, patients needed 90% or above adherence to avoid risk of virologic failure. So the message here is that antiretroviral therapy is relatively unforgiving, and risk of treatment failure and viral resistance can develop when patients don't take their medicine every day, which is difficult because they get tired of taking medicine every day. And we hear this often from our patients. And so there is a lot of interest in the patient and provider community in an alternative method. So why would we think about long-acting treatment? Well, obviously less frequent dosing, avoidance of the pill fatigue that we see so often, potential improvement in bioavailability, less adverse events, less drug-drug interactions, protection of health privacy, which is particularly important in HIV because of the associated stigma that patients may face. But does this result in improved adherence? Well, I'll present the data that we have and you can decide. So there's actually quite a lot of long-acting antiretroviral agents in development or clinical use as outlined on this slide. Not all of them will make it, but some of them are quite far along. The two that are the most are cabotegravir, an integrase inhibitor, and rilpivirine, a non-nucleoside reverse transcriptase inhibitor, both formulated as long-acting injections. And here's an example of some of the phase 3 trial results that have been generated. So this is the so-called Atlas study, which is a switch study, and there's a partner study called FLAIR, which had a similar design and was for patients who were treatment naive. And the primary endpoint at week 48 is shown here. And as you can see in the green bar on the left, virologic success was very high in the injectable arm and in the purple arm, which is continuing oral therapy. And so this met the non-inferiority margin and supports development of this strategy going forwards. Of some concern, though, is the fact that the few patients who failed with virologic failure did also develop resistance-associated mutations at the time of failure. And these were mostly patients that were from other countries outside the US and had non-clade B virus. Important to note, though, we cannot just blame low plasma exposure for the failures because the patients who failed had similar, although at the low end, plasma concentrations to the rest of the study population. And in fact, adherence with study injections was very high in both Atlas and FLAIR studies, which is good, but does not tell us much about how this strategy might work in patients with less than optimal adherence. So do our patients want antiretroviral therapy by injection? Well, in the phase 3 trials, patients were surveyed for their satisfaction and preference for injectable therapy. And not surprisingly, as this is a select population who signed up for the studies, there was high levels of both at week 44 and at week 24. And these are extremely high. Patients really liked this. And I've observed this myself as a site investigator for these phase 3 trials. I've actually been surprised how much patients actually like it. But there are multiple published surveys of patients not included in the long-acting injectable studies, so asking about their interest and attitudes to getting their antiretroviral therapy in a long-acting formulation. And this is one that I did some time ago with a colleague at Johns Hopkins. And as you can see in the far right bar, a high proportion were interested in getting their medicine this way, particularly if it was administered once a month. So what can we learn from PrEP studies? Well, you all remember this seminal article from 10 years ago showing that tenofovir FTC given orally every day was effective in preventing HIV infection in men who have sex with men. These are the primary data showing a clear difference, although only a 44% risk reduction in HIV acquisition. And subsequent PK data, I think, go a long way to explaining this. So on the left is FTC, on the right is tenofovir, and you can see a marked difference between those who tested positive and those who didn't in terms of levels of the study drugs in their plasma, suggesting that non-adherence was the major region that this study was not more successful. But now we have a head-to-head comparison of cabotegravir given every 2 months by long-acting injection versus the same one pill once a day strategy. Here's the study design. It's called HPTN 083, and patients were randomized to either injectable cabotegravir or oral TDF FTC and followed for 3 years. And here are the primary data for this study showing a clear benefit to the cabotegravir arm, which is the orange line, and a 66% reduction in HIV incidence, which is a clear demonstration of the benefits of a long-acting formulation as compared to standard one pill once a day preventive therapy. So what can we learn from other disease areas if we don't have a lot of data in HIV about adherence and long-acting formulations or non-oral formulations? So as you probably all know, these are widely used in the psychiatry field for schizophrenia, where adherence is also a major issue. Osteoporosis, a long-acting infusion offers convenience for contraception. This provides patient with choices, and prostate cancer, actually, you get all three. So lessons from contraception. These are contraceptive failures with the different methods of contraception available. On the left, there's pills, injectables, and implants. And with perfect use, rates of failure are extremely low, but with typical use, as you can see, particularly with the oral formulations, they're considerably higher. And so with implants, the typical and perfect use are the same. So what are the impact of long-acting injectable antipsychotics for patients with schizophrenia? So the majority of patients with schizophrenia relapse after 5 years, mostly because of poor adherence, and discontinuation rates for oral antipsychotics are high, at least a third of patients. Non-adherence is associated with poor outcome, not surprisingly, and there is a large body of data supporting the fact that long-acting injectable treatment is associated with lower rates of relapse, discontinuation, and hospitalization. Also, cost effectiveness and quality of life, and patients actually like it. Similarly, in osteoporosis, patients don't really like to take bisphosphonates every week. At least a third don't take them consistently, and this gets worse over time. And again, the data overwhelmingly support patient preference for a once yearly injectable product, in this case, an infusion of zoledronic acid. So what about data for long-acting antiretroviral therapy in patients with adherence difficulties? So as I mentioned, all patients in the clinical trials had good adherence. They had good adherence in the phase 3 trials, and they needed to have good adherence to be eligible for the trials. So this is a very select population that doesn't really inform the discussion very much. But there is an ongoing study sponsored by the ACTG called Latitude, which is enrolling people with HIV infection with previous non-adherence. And the first step in this trial is oral antiviral therapy with financial incentives. And again, the patients do need to achieve a viral load of less than 50 to proceed to the randomization stage where they get long-acting antiviral therapy versus ongoing oral standard of care. And here's where we are to date. The team have screened almost 450 participants and enrolled 202, so a high screen failure rate, and the demographics are shown here. So this is a very important study, but it will be a while until we are able to see results. We have a few from the compassionate use programs that the pharmaceutical sponsors developed for patients that need to take antiviral therapy parenterally. So they've enrolled 35 patients from 10 countries. Here are the demographics, and at the bottom you can see the primary reason for patients needing compassionate use injectable therapy. And I think most of us clinicians have patients in our populations that fit some or more of these criteria. So what are the data to date? So this slide is a bit hard to read. The green bars are baseline virus loads, and you can see here the virus load at last follow-up, and most patients did achieve undetectable viremia, although not all. And in fact, 5 or 14% of these 35 had incomplete responses and stopped the injectable treatment. 4 of them had a resistance-associated mutations to NNRTIs and 2 to integrase inhibitors at failure, which is also a concern. So one of the concerns patients providers have about managing patients with monthly or every other month injections is what to do if patients don't show up for their injections. So there is a strategy for this based on PK modeling. And in the studies and in the model, missing injection within 7 days was no problem. Greater than that, though, the patients require what's called oral bridging, which is where they take oral cabotegravir and rilpivirine until they can get back in for their injection. And depending on how late they are, the injections may need to be the loading doses again, or can just continue with the regular injection dose. So as long as you can actually find people and get them some oral medication to tide them over until they can come in for an injection, this is probably manageable. But implementation of this long-acting injection therapy is going to be challenging. So this is a cartoon of some of the issues that will need to be addressed both at the patient level and at the clinic level in terms of workflow and logistics. We don't know yet in the US how this is going to be handled by insurance companies and antiretroviral treatment providers, how much it's going to cost, but change is coming. So those of you that are in the business of treating patients with HIV need to get ready for this. This strategy is already approved in Canada, cabotegravir and rilpivirine. The European Medicines Agency has recommended approval, and the US FDA is anticipated to approve this in the first quarter of 2021. And with that, I'll just thank everyone for listening and the organizers for inviting me and take any questions.